Hello, everyone. This is Steve Reed here. I'm not sure who's supposed to be facilitating the session, but I'm here in person in PG1 with one other member, Ansimpiwe, and I will just assume that Taslee, you'll take us away, and if nobody else pitches up as the facilitator of the discussion, I'll take that role. So, Taslee, I think you're probably known to everybody in the room, and I see quite a number there. How many, Simpiwe? 17. Okay, so it's 4 minutes past. I think we can start. Over to you, Taslee, and just put your slides on full screen, please.
Will do. So good afternoon, everybody. I'm Taslee. Some names I don't recognize. Just by way of brief introduction, I am a senior lecturer in the Division of Family Medicine. My primary responsibility is convening the postgraduate programs. And what I'm presenting this afternoon is part of my PhD research. Can I just ask you indulgement for 1 minute while I fetch an extension lead because my battery power is running low and it's load shedding where I am at the moment. So just 1 minute as I do it.
Yeah, that's fine. We'll hold on and see if any others join us. You have to have both. Okay, so now it's on. Okay? So leave it there, and I'll.
Apologies about that. I was charging up my laptop, but it hasn't outlasted load shedding. So let's get into this conversation. So we're talking about doctor-patient relationships in an African context. The formal topic that of my PhD is reimagining doctor-patient relationships in an African context. And I'm approaching this phenomenon from an educational perspective. And you'll see that my primary supervisor is already in the room, literally. My co-supervisor is Prof. Susan Levine. Where did this all start? So my journey started a few years ago when I worked on the outskirts of Cape Town in a place called Delft. And in Delft, a very, very poor, difficult community, lots of socio-economic problems, gangsters and drug abuse, etc. Typical of a kind of urbanized township in South Africa. One of the big problems I was faced with is that many of the young doctors coming through were unable to connect meaningfully with these patients. There was this large disconnect. And then in other places that I'd worked at, I saw something similar. I saw the same phenomenon in the rural, and I saw the same phenomenon in other urban settings that I'd worked in. And this despite the fact that for the last 20 years in our medical schools, we've been teaching professionalism, ethics, communication skills, etc. So to my mind, there was something definitely deeper going on, something which was beyond the technical skills of being able to speak properly and use the correct words. And so I wanted to look at this phenomenon more deeply. And that animated my interest and motivated this PhD. When we look at the literature around doctor-patient relationships, we recognize that it comes probably stretching back about 300 years. One of the central ideas in doctor-patient relationships is that at the epicenter, I would argue, some people wouldn't. One of the essential components of any health system is this encounter between a clinician and a patient. Now, the nature of that encounter, and then multiple encounters leading to a relationship, the nature of that relationship is influenced by a worldview, by an episteme. And that worldview has emanated from a very particular philosophical and, in our context, geographical context. And I'm not going to go through all of the discussion because I want to have time to talk about the actual studies. But what I'm trying to show in the slide is that we, in a South African context, have been guided in our thinking and our teaching about clinician-patient relationships from factors which originated outside of our context. And so just very quickly, Michel Foucault looked quite critically at doctor-patient relationships in his book, The Birth of the Clinic. He described the medical gaze with the doctor as the powerful, knowledgeable practitioner, and the patient as this passive, disempowered, not even a person, object that is the agent of bringing the disease into the room. And he describes the classic clinic as being the triad between doctor, patient, and disease, where the patient is basically just a passive participant. And the fight, the struggle for healing is between the doctor and the disease. And what we then saw emanating out of that initial struggle between the doctor and the disease in the pre-technology era, we saw that escalating with the rise of technology. And with the rise of technology in the 1800s and the 1900s, we also saw a rise in medical specialization, which accompanied these technological advances. Particularly, medical education saw the proliferation of medical specialties from the 1920s onwards, and medical schools were set up, which excluded generalists from their faculty and had no generalist education, excuse me, in their curriculum. And in the second half of the 20th century, from around the 1950s onwards, people started realizing that, hang on, there's a traditional family doctor who works out in the community, who's been excluded from academic work. And so, particularly from the fields of psychology, psychoanalytics, some scholars started looking at ways of building a body of evidence around the psychosocial dimensions of healthcare. And I mentioned Carl Rogers, a psychoanalyst, the Balance, Michael and Enid, who were instrumental in defining the emotional dimensions of disease, and also the idea of patient-centered care. George Engel, who translated, who invented, one could say, who developed the biopsychosocial approach for psychology from general systems theory. And then Ian McWhinney, the Canadian professor of family medicine, who synthesized the modern principles of family medicine and led a team which developed the modern techniques, the current techniques that we have in having consultations and engaging with patients in terms of the biopsychosocial model, which looks beyond just the biomedical aspects of disease, but also takes into account the psychosocial. So what we see is an evolution over time from a biomedical model, then separately or in response to the biomedical focus, only the psychosocial coming from the world of psychiatry and psychotherapy, and then family medicine as a discipline synthesizing that into the biopsychosocial model. And this was introduced into the South African curriculum in the 1990s. I'm not going to talk too much to the slide, except to say that our curriculum is informed strongly in the ethics, empathy, and professional identity formation domains by scholarly work which has originated outside of our context. And when you think about these humanistic interactions, it becomes quite important for us to think about what has been generated within our context. In this instance, if you look at the curriculum in family medicine training, the answer is very, very little. There's added impetus within medical schools across the world for a greater focus on humanist elements within medicine, and the medical and health humanities is the discipline, one could call it, that is looking to bring that much more strongly. And so there is a movement towards humanizing health professional training and care. And the question that I ask of the literature, not necessarily of this project, is how can we engage with this in our context? Surely our relationships are strongly influenced by contextual and cultural factors, individual factors, which we all bring to the table. And while we may learn certainly from colleagues elsewhere in the world, how do we learn from our own context? So when I was thinking about all of this, I thought, what's the way to approach, to frame my thinking? And remembering that I'm doing an educational project, I thought Jack Mezeroff's transformative learning theory describes a process of perspective transformation from an established or an existing perspective of how you see the world within a particular phenomenon, and describes a process of how that gets transformed as a result of certain contextual experiences, context-rich experiences, and this really grabbed my attention. And secondly, set of principles as described by John Mbiti, which describes Ubuntu as an African philosophy, because I wanted to think about our experiences in ways which were real to our geographical and cultural context. And then because we need to think about our work in ways that makes power explicit, I leaned on the work of Michel Foucault, looking at that dynamic that I described earlier, which he calls the medical gaze. And so the aims and objectives of the study was firstly to understand how the doctor-patient encounter was influenced by student learning using a transformative learning approach. And secondly, to develop a model of teaching about the doctor-patient relationship in an African context. And so we explored the process of student learning. We listened to patients. We actively sought out patients' feedback about their encounters with doctors. We sought out feedback from educators who were involved in the training of our students. And then finally, synthesized an approach to teaching about doctor-patient relationship in an African context. Now, just because of the nature of this talk, I'm just going to focus on one objective, and that is the patient feedback for this afternoon. I am doing another talk at 1 o'clock, which is going to look at all of the results. But I think importantly, patient feedback provides a very important contextually rich background to understanding what the students experience. So the different bits of data would be interlinked, but in this instance, there's richness just in listening to what the patients had to say. So that's what I'm presenting this afternoon. But a background in terms of what the context of the study was. It took place within the context of the first year postgraduate family medicine training programs. We have two programs, a diploma and the master's. And in the first year, the students all sit in the classroom together. They have daily clinical work, and we expect that they sit and reflect about their daily clinical work and weekly classroom-based teachings. And in the first year, we have 3 modules, which deals with the basic principles of family medicine, deals with ethical and legal issues under the umbrella of professional practice, And then we round off the year with family and community-orientated care, where we expect them to go out into communities and engage directly with people where they live. We had 3 cohorts. We had a patient cohort with 25 people, a student cohort with 12 people, and an educator cohort of 5 people. And as I said, I'm only going to speak this in this session to the patient cohort. Sorry, my cat is getting involved in this. We gathered data from these patients immediately after they had consulted with one of our postgraduate students in a clinic. We gathered data from clinics across Cape Town, from Masiphumelele, Ocean View, Crossroads, Gugulethu, Atlantis. So all working class, lower socioeconomic communities. We developed an interview guide based on what our research objectives were, and got 2 lay people to interview patients in a language of their choice. So it was either English, Afrikaans, or isiXhosa, translated and transcribed into English, and triangulated the transcribed data with our field notes. I'm not going to speak to the student and educator cohort in this talk. We analyze the data inductively as it relates to the patients. The deductive analysis related only to the student analysis, so I'm not going to speak to that part of the slide. And for each conceptual frame, we looked at themes emanating within those frames inductively. Just a quick rundown of who these patients were in the first column. Most of them were female. isiXhosa was the most frequently spoken language, though not far from English. And most of them had high school education. So, getting into the findings. 3 key themes emanated, and I'm going to show the raw data in a moment. But I just wanted to give an architecture of the findings related to the patients. 3 key themes emanated from this data. The first theme spoke to validating patienthood. And here the patient spoke about being heard, the story of suffering being heard, being examined, the touch, being touched by the doctor, validated their suffering. Then the second key large theme was that of validating personhood. And the validating personhood spoke to patients' experiences of the doctor's ways of doing and being. We'll speak to that in a moment. And the second sub-theme was around building trust, which was not unconditional. Neither was it necessarily vested in the person who is the doctor. And then the last key theme that emerged from the patient data was the patient as a critical agent. So, on being heard, I just have 2 short quotes. Patients had some interesting things to say. So the one patient says, when the doctor listens, so that backgrounds this quote, we get to know each other, we get to understand each other, and then adds a value dimension to that. And that is, which is very important. And they ask me how I am and how my health is doing and how I'm getting on. And the second quote is, this is in relation to doctors who this person had previously encountered and comparing this current experience with previous experiences. The patient says they don't ask you what you are feeling. They just do things and rush. But this one takes time. And so patients value the idea, or they value the experience that they have when they are being listened to, when the story of the illness is being heard. And I call that the validation of the story of suffering. Each of the patients who come into the room has a story to tell. And when the doctor takes the time and the effort to listen to that story that validates the person's story. And we'll come back to this important theme in a few minutes. The second sub-theme related to this idea of patienthood was that this patient's experiences of being examined. And one patient says, I can say most of the time when I come to the hospital, I didn't get the time for the doctor to check me for everything. And the word check obviously means examine. It was just previously to ask me questions and writing. But when I attend this doctor, they check my body, they ask everything, so I'm happy with it. Now, a few things jumped out at me here. The first is that the patient had a certain expectation based on their previous experiences. And that expectation was surprisingly challenged when this doctor validated their suffering and took the time to examine. And they checked the part of the body that was problematic. And then the patient responds with emotion to that experience. The patient says, I'm happy with it. And for me, that tells quite an important story, that the patient's experience of the doctor's examination was deep enough to evoke this positive emotion. Now, this is not just the one quote where this came out. This was an oft-repeated sentiment from multiple patients. And so another patient says, it's the way he treated me. He told me all that I needed to hear, even for my high blood pressure. Today, he even examined my eyes, something that is not normally done. That's why I chose this score. But today, I felt I was given a thorough examination. I felt confident about my health and my treatment. So here you have the patient who is celebrating something which we would regard when we're teaching our students as being something which is within the ordinary. They should be doing all of these things. But for some reason, our patients are experiencing healthcare within these facilities in a very, very different way. And so what we regard as fairly simple, everyday, mundane activities, when we implement those activities, the patients respond in very significant ways. And so the thoroughness of attending to the suffering, the listening to the story, and then the examining of the body in the area that is suffering validates that patient's suffering. And so when I look at those two sub-themes of validating of suffering and validation of the story of suffering, it then enhances the patient's identity as a patient within the cultural context of the health facility. The patient gets validated in their role that they are bringing into that relationship. And so it's not just enough, in my opinion, to be thinking about patients as people with illnesses. There is a lived experience attached to that illness, which is mitigated through how we respond, how the doctor or the nurse responds to the suffering attached to that illness. And so the identity of patienthood, of being a patient, becomes quite an important concept that the patient carries with him or herself into that clinical encounter. So I want to park that idea for one moment and move on to the next theme, and that is ways of doing and being. So patients responded when asked about what they liked about the doctor, about the clinical encounter. The one patient says, the doctor that I've just seen is a wonderful doctor. For the way that the doctor treats me, speaks very nicely to me, and makes me feel good. So you see again, it's not only the fact that the doctor did something, there is a description of the way that the doctor did that. So there's a way of doing that the patient is tapping into quite intuitively and perceptively, and then responding with an emotional response. It makes me feel good. There's an interest from the doctor, then the way in which the doctor engages, and then the patient responds in a certain way. And the second quote, I chose that circle, so it's a kind of a score that we use to stimulate the conversation, because it feels like the first time that I had a doctor examine me like he had. And the way he spoke to me, the way he asked me the questions, I was not even afraid to answer the questions. So that's quite kind of an informative comment, because it implies that previously, if the way of being that the clinician carries into the encounter is different, it evokes a different response to the patient. And this patient says it dispelled fear purely because of the way in which this doctor had spoken to her. I made the decision because, like I just said, the way he spoke, the way he looked me in the eye, and even the way he touched me, he made me feel very, very comfortable. So this is also quite an insightful statement from the patient, because it's not what the doctor did, it's how the doctor did what he did, how he connected, and then how he examined that the patient responded to. And then the last quote, because it was how the doctor treated me when entering the room. From then on, it was just a good relationship between me and the doctor. The way he treated me through the whole appointment, for me, he did everything perfect. I was satisfied. Some doctors, it is just you're a patient, they treat you and you go. They don't go that extra mile to make you feel comfortable. So this to me speaks to the value that the patient applies to how the doctor carried himself in this clinical encounter. And I think what was quite interesting for me is that first highlighted section, how the doctor treated me when entering the room. So that was an instantaneous decision that that patient had made almost in a precognitive way. This was before the consultation had unfolded. There was already an intuitive evaluation that the patient had applied. So now we can start to see how critically engaged the patient is in that encounter, reading the doctor's attitude, reading the doctor's way of doing things, and then responding either emotionally or cognitively to how the doctor is presenting him or herself. And so it becomes kind of a dance that the patient is following and the clinician seems to be leading. And then what flows out of this idea of when patients value the way that we do things and the way that we are and the way we carry ourselves, this idea of building trust. Now, we teach our students about building trust all the time, but we ask, how do we build trust? And the patients tell us it's in the way he treated me. He told me all that I needed to hear, even for my high blood pressure. Now, one would have thought that with the amount of people with blood pressure in our communities that they're seeing doctors and nurses all the time, there'd be pretty high levels of engagement, but it seems as if not. Today, he even examined my eyes, something that is not normally done. Yes, because of this thorough examination, I felt confident. Having confidence in the doctor's performance is quite an important step towards trust about my health and treatment. Before him, we were complaining about how we are treated here. There was one time that I even decided to stop coming because of this poor treatment. And for me, this deciding to stop coming because of the poor treatment is a sign of lack of confidence, loss of trust, and how that trust can be rebuilt by thinking consciously about ways of doing and ways of being within the clinical encounter. The things that make a good doctor is to give the patient the time. When he gives the patient the time and asks for everything, it is good, and they must follow the answer of the doctor. So I looked at this quote and I thought, there's something here that's interesting to me. The patient is saying that the trust is not unconditional. Obeying and following the doctor is not an unconditional act purely because I'm the patient and you are the doctor. It's conditional upon how the doctor manifests, either in doing or in being within that encounter. And so building trust then becomes something which qualitatively emanates it's not a kind of a priori assumption that patients are coming to us because they trust us. Trust is something which emanates out of the engagement. And it emanates once the patient has made this evaluation of whether or not they can have confidence and trust this person they're engaging with. And when I think about these ways of doing and the building of trust, I asked myself, what does this mean? What does it mean for the patient to want to be dealt with in a particular way and to be engaged with in ways that they can also feel present in the room? And so I interpreted that as a validation of their personhood, as opposed to the validation of their patienthood, which is a particular identity which enters into the room. But when we think about them as a person being validated as a human being within that clinical encounter, it is a little bit larger than the particular role of patienthood. And I want to hang on to this because later on in the thesis, I come back to the idea of personhood, particularly personhood within the framework of Ubuntu. The third key theme that emanated from the interviews was that this idea of the patient as a critical actor, which really challenged my thinking. When we deal with patients, when we think about patients who live and attend facilities in these underserved areas, we constantly think of the power differential, that these are vulnerable, disempowered groups of people. And the patients, they surprise me in their assertiveness and in their astute evaluations of their experiences, which has really radically altered my own perception of patients. So the one patient says, I would go for a high rating for him because of previous experiences with doctors. To speak honestly, this was the best service that I got. I don't know why, because he was maybe being observed. So just the background to that comment is that I was also in the room along with the doctor, sitting in the corner quietly observing the consultation. But to me, he did everything good. Since I've been coming to this hospital, it was the first time ever to be treated like that by a doctor. So what does this tell me? What this quote told me is that this person uses past experiences to evaluate current experiences. Now, and they do that explicitly. It's not an implicit, vague evaluation. It's an explicit, clearly thought out evaluation, which this patient, who we might have regarded as disempowered and possibly undereducated, has reached based on the encounter with his doctor. And then the other astute observation is possibly this doctor is just acting because he was being observed. So there's an expectation of how patients want to be treated, and then there's this evaluative component based on their own experiences of coming to the facility as patients. And the next quote speaks to that directly. Some doctors just examine for the sake of doing so. They don't pay attention to you. They examine and then write down your prescription, and then they tell you to go to the pharmacy. If some doctors do that, they don't check you properly. So clear expectation from the patient side of being checked, of having a thorough assessment.
You're cutting out every now and then.
All right, I'm sorry about that. Yeah. Is that better?
Fine.
Okay, so clear expectation that this patient had of the current encounter, but also, sorry, did I leave the room? Okay, I'm still here. But also using their past experiences and being quite explicit about what they didn't like about the experiences. And so for me, as an educator sitting and looking at this, I thought, wow, these patients are empowered. They might not have decision-making capacity within the health system, but certainly within their own lives, as people that are able to make evaluations, that are able to hold people to account, the doctors, the clinicians that they are seeing to account, they're demonstrating a high degree of personal power, of agency. And so just to start rounding off the presentation, 3 ideas that came out for me quite strongly from the results I've just presented. The first is the educational potential of suffering as an intersubjective bridge. We'll talk to that in a moment. And the second is the importance of emotions in this intersubjective space. And then the third, I'll come back to this, I think for a long time, come back to this idea over and over again, the patient as a powerful agent. So the potential of suffering. I think this is not a new idea. Ian McWhinney, way back in the 80s, wrote about the ideas of this tension between disease as a biomedical entity and illness as experienced by the patient. And oftentimes, actually, I won't say oftentimes, most times at medical schools, we teach about disease and the illness experience, the subjective illness experience, which is always associated with some degree of suffering. I think I just want to talk about that for a moment. Suffering is synonymous with healthcare and should be synonymous with health professional education. There is no clinical encounter I can think of where suffering is not part of the equation. Now, quite importantly, related to this, is that if we start thinking that suffering is a central to what we do as educators and as clinicians, then we need to understand that suffering. And Cecil Hellman speaks to the anthropological dimensions of suffering via the cultural expressions of suffering. And once again, we've ignored this largely in our core medical training of our undergrads, and we attempt to do it within family medicine, but I certainly do know that it's not widespread across all the disciplines. And then the medical and health humanities have focused on suffering for many, many years as a central element of the human condition. Now, you can see where I'm going with this argument. That because we've been ignoring the human dimensions of disease for such a long time, we are unable at the moment to find clear ways of teaching about suffering. And so suffering becomes something which we need to start thinking about in a very deep and meaningful way in our curriculum. And just as an example, with the rise of technology that I spoke to a little bit earlier, we were able to measure almost every human, in every manifestation of disease in the human body, biomedical markers, blood pressure, lung function, CT scans, radiology, all of these things we can measure. We still don't have an objective measurement for pain. We don't have some kind of technological tool which allows us to quantify human pain. And yet, pain and suffering is what brings patients to us. It's why we train thousands and thousands of clinicians every single year. And it's something which, when we speak about chronic management of pain, we say, oh, this is a subjective. Yes, it's subjective. How are we teaching? And as we speak about subjective and we think about relationships, the idea of entering into that space between people, between the two subjectivities, the intersubjective space, which Belong, the psychoanalysts from the Catonian, he feels quite strongly that this is the space in which emotions operate. Emotions operate within this intersubjective space. It challenges how we engage with others in our immediate environment. How can we start engaging with emotions within the context of clinician-patient encounters? Emotions are quite important. I came across Martha Nussbaum, who's a political theorist, who speaks about emotions providing the energy for action within society, even at the political level, within collective society and at individual level. Emotions provide some kind of internal motivation towards action, whatever that emotion may be. Nussbaum says that the highest motivation, in her opinion, is love, which pushes towards right action. And so when she combines love and justice as two key components of a healthy society, we start seeing how society could possibly evolve on an ongoing basis. What does that mean for us as health educators, as people who are clinicians engaging with patients and educators engaging with students? How do we enter into this intersubjective space and think about it from an educational perspective? And then the third key idea I want to bring out, because it's something which struck me like a lightning rod, is this idea of the patient as powerful. The patient is clearly making evaluations on a constant basis. Now, those evaluations are maybe not based on some kind of a theoretical framework which was constructed and which they've read in a book. They're making those evaluations intuitively and semiotically. So they're making rapid fire evaluations in a precognitive manner as soon as they engage with us. And then those evaluations are either challenged or they are strengthened in the subsequent non-verbal semiotic engagement that we have with them. They're looking at what we're doing, how we're doing it, how our mannerisms are, how we're carrying ourselves. Patients are core to decision making. We recognize this. When we think about power traditionally in the doctor clinic, in the patient clinic, in the clinical encounter, we only think typically about decision making. And I'm thinking, how do we think differently about this? And then the third arm of this theory around power is that of implementation. So typically a clinician would see a patient for 15 minutes and off the patient goes, and the rest of the time the patient's on his or her own, making decisions and acting or not acting upon advice. We call it compliance and adherence. We say the patient is a defaulter. Our language speaks to the powerful way in which we view ourselves. The patient is either compliant with our orders, is adherent to our orders, or defaults from our orders. I challenge us to think a little bit differently about that. And so in conclusion, patient perspectives of clinical encounters are potentially powerful influences for medical educators if we can think about creative and innovative ways of engaging. A reimagining of clinician-patient encounters, specifically in African, decolonial, global South, underserved context. Context is core to how we think about a reimagining clinician-patient encounters. And then I think this becomes an obvious way forward, exploring paradigms, epistemes, knowledge systems, and pedagogies outside of the existing biomedical models. I'll stop there. Thanks, Steve.
Thanks, Taslee. Excellent presentation and very articulately put. Thank you. You've nailed some things that we often don't speak about. So I'd like to open it to questions and comments. Landon, go for it.
Thanks, Taslee. It was a really presentation, sort of clear and engaged, and thought-provoking in many regards. Taslee, I wanted to ask, I suppose to pick up on your title, or the title of your PhD, I wanted to ask about let's call it the African, what is uniquely African here versus what is actually cross-cutting, maybe in terms of pan-human or sort of modern interpersonal interaction. That is, and and I suppose I'm questioning what do you think is unique and what is generalizable given the presence of sort of African in your title, but also in some of your background theory.
So Landon, the title is purposefully specific. It's about an African context, and the reason for that is that we recognize that Africa is not a homogeneous entity. So I cannot imagine that anyone can then speak for Africa. I speak for this context in which is a case study in an African university on the southernmost tip. So I speak to something which is very specific, our current experience. I think when I hear what you're asking about, some kind of a globalized or let me just get the light up behind me. That's better. Speaking to a globalized or universal, well, let's call it values or principles. I think that's something which we could engage with, but which I am not yet at the point in terms of this thesis ready to engage with. And I'll tell you why. We are starting to define what it means to be ourselves in our context. And I think for myself, when that definition becomes clearer, we are then able to engage with other knowledge systems, with other cultural contexts, with other ways of being. But within my thinking, within medical education, where we are now within the clinician-patient relationship, for me, this was a first tentative step into something which was almost completely new. There'd been so many assumptions made about what it means to be a clinician in relationship with a patient and what animates our curriculum, that it's almost as if I'm hesitant to get into some universal discussion until I know what lies under my own feet. I don't know if that answers your question. So I'm hedging because I'm hesitant to answer, and I certainly don't want to be someone who says I'm a spokesperson for like broad swathes of lived experiences. I don't think I can speak.
Universal theory, yeah.
Absolutely. Taslee, absolutely, it answered my question. Steve, may I ask a quick follow-on?
Sure.
Which is just, Taslee, do you think you're working in a context of, let's call it Western medicine, for lack of a better term. In other medical contexts, traditional African medicine, Eastern medicine, Ayurvedic medicine, do you think are there similar bodies of work? Do you think the results would be fundamentally different? They're different. That is there maybe not an African or a universalist, but is it informed by Western medical tradition?
So my work is informed from my training as a Western biomedical practitioner. And I think I limit myself consciously to that paradigm because this work tries to make some kind of critique of the Western biomedical paradigm. Certainly, there are different ways, and I haven't looked at it deeply enough to be able to talk about it. But number one, indigenous healing systems across the world seem to connect the actors within those healing systems seem to connect differently to the way in which our current biomedical system, which is based in scientific rationality, which is based in a Cartesian mind-body dualism assumption. So there's a deep philosophical reason for why we are connecting with our patients in the way in which we do within the Western biomedical system. That process has not happened in indigenous healing systems. Indigenous healing systems have clear ideas about personhood, about who the healer is and what identity of the patient is, and how to live within that world. And so, while I can't speak to the deeper dimensions of indigenous systems, I can say that it is a radically different proposition to what we have within Western biomedical systems. The reason I limit myself to the Western biomedical system is precisely because I think there's a need for us to challenge the dominant episteme, which has been growing for the last 300 years within Western institutions. So I limit myself only to the Western biomedical for now.
Thanks for that. We're going to run out of time soon. I see Feroza's hand.
Hi, thank you. Can you hear me?
Yeah.
Yeah.
Okay, great. Taslee, this is a fantastic body of work and so important and relevant. I have a comment and I have a question. The first one is with regards to your methodology, the fact that you were in the room observing everything. Some may call it an introduced bias, but I'm hoping that you will appreciate that that actually gave you a lot more rich results. Because when I look at all the comments, your interviewees were drawing comparisons between the current fantastic model of care compared to previous, right? I hope that you appreciate that and that you will actually use that as a justification if that criticism ever does come up. And then also, it's something that you touched on, the 15-minute consultation, you know, and so I have to wonder to what extent do our health system issues actually impact the quality of that doctor-patient relationship and interaction. And I'm not saying that just because you have 15 minutes with a patient is an excuse to treat a patient in an undignified manner. But a lot of people, a lot of doctors may say, but we just don't have time. We have to get to the point. So what changes need to be made in terms of that to enable what you are talking about in terms of how we manage our patients?
Yeah, I mean, Feroza, thanks for the comment initially, and certainly my position as participant in all of the data generation processes is kind of outlined quite clearly in the reflexive component of my project. Second question around the health system. I had a pretty in-depth discussion yesterday with students about model injury to students and to clinicians. However, what was interesting, and we didn't speak to the student data in this, but the student data indicates that when the clinician changes the habits of mind, what Meserov calls habits of mind, you change your way of looking at the world. So they changed the way in which they transformed the way in which they looked at their encounters with patients. Something clicked upstairs, and then the patient started responding to them differently. Whether it was 5 minutes or 10 minutes or 15 minutes, I think we get caught up in a discussion about the materialistic elements of our health systems. And we then lose the non-material, the social and emotional components, which can mitigate a lot of the inflexible structural barriers. And so a lot of my argument is built around how do we then engage with these non-material influences, let's call it for want of a, or factors, and bring that to bear on some of the more inflexible, kind of resource-dependent, structural and material kind of systems within which we work. I hope I've answered that question. So there's this psychosocial non-material dimension, which the students, I mean, they surprised me. It mitigates powerfully against this resource-constrained environment in which they're working. Very, very powerful.
Taslee, we've got a few minutes left. Lionel, you have a comment or a question?
Thanks, Steve, and thanks very much, Taslee, for a really excellent presentation, and particularly for my sense of enthusiasm again for reflecting on the space. One of the things that happened in my own PhD was this idea that the patient-doctor relationship may be, in fact, the unit of accountability. And that came to me as a surprise in that work, because I was looking at a more social dimension for social accountability. I did want to make two comments, Taslee, that may or may not be able to influence your thinking. I just wanted to pick up that in your conceptual framework, you've put Ubuntu and power as two separate bullet points in each of those components of a conceptual framework, which I think is a really important reflection. But I think I do want to challenge the notion that it's either or, but that in fact that Ubuntu itself is a reflection of a spectrum from power to vulnerability. So they're not exclusive of each other. They're manifestations of the way in which power and vulnerability may be exercised or experienced. And I think I really thought that conceptual framework was great, but I did think it created a dichotomy for the two things. And then I want to warn Taslim a little bit about the use of accountability in what emerged from your patient interviews. I think Rose has raised the issue of your presence in the room and the extent. So I think that idea of the distance of the analysis of the interviews from the patient's vulnerabilities is quite an interesting thing, and what that may do to your thinking. But just the way in which you use the word accountability, I think I would like to ask for more on the expressions of accountability and judgment of accountability of the practitioner versus the patient's capacity to challenge the doctor's lack of accountability. Because my own experience is that the patients often don't have the discourse for holding their professionals accountable. They know what it should be, and it is expressed in terms of love, respect, dignity. But I think just be wary of hearing them say things about a judgment of their encounter with the professional and translating that into their capacity to hold them accountable. It may be a jump that could be challenged.
Thanks, Lionel. Appreciate that.
Our time is up. Do you want to respond in 15 seconds?
15 seconds. So I completely get the connection between Ubuntu and power, and in the full thesis, it's quite explicitly intertwined. You can't think about Ubuntu and it is not a liberating ideology which changes the power dynamic in that clinical encounter. So I completely get what you're saying in that regard, and I do take on board the comments about accountability. Thank you, Lionel. I appreciate that. I'll have a relook to see whether I need to strengthen that argument somehow in the thesis. I can't remember the depth in which I go into discussion in the thesis offhand right now. Thank you.
So thanks very much, everybody, for attending. Taslee, and thanks for an excellent presentation. We have one other comment from the room here, but we haven't got time for it. So we're going to have to close. I know that people have other appointments. Thanks so much, and have a good day.
Bye-bye.